I'm going to talk about something that I feel really underqualified to talk to you about, schistosomiasis, but at least I can talk about how it presents in the UK. I thought I'd start off by finding out how much you all know already, tell you a little bit about an acute case and a little bit about a chronic case, and then a couple of papers that sort of look at their presentations in the UK. So, you don't need to write this down, but it might be helpful if you want to jot it down on a piece of paper for a little bit of a quick wake up after lunch, after what was just such an inspiringly emotional hour. First of all, does anybody want to admit, has anyone actually had schistosomiasis? Yeah, so you could just go and have a long coffee. Has anybody treated more than a couple of cases of symptomatic? Great. So a few people have, but actually that's quite reassuring that hopefully I can add something to your knowledge. So just on your own, or you can confer with a partner if you like and have a winning team. Tell me who this chap is. And then tell me why I think this picture is much more apt and what it's got to do with anything to do with schistosomiasis. And we'll go through. I've only got 3 questions. Don't worry. We can go through these. And then these 3. So a classic question for those people who've done the diploma, which I haven't done, by the way, just so that you don't have any high expectations. So just name the ova. Tell me which one is associated with the most severe acute illness, and which one is used to forms the basis of the serological test in the UK. Okay, so anyone want to shout out who is the first person, and appropriately a German, is going to reply?
Is it Otto Billhartz?
It's Theodore Billhartz, yes, but pretty close.
It's brother.
Exactly, it's his brother. And he was a German physician, of course. And what's he famous for?
Yeah, he was probably discovering the vector association with the snails, etc.
Yes, sort of. Yes, he. So he in 1852 described. He was living in Cairo, and he was doing lots of post-mortems, and he found the worms in the vesical plexus of some Egyptians, and he then went on to describe it and describe hematobium and Mansoni in Egypt, and everyone credited him, and hence it was called Billhartzia. Does anybody know why I think this is a better picture? So exactly. So actually in Japan in 1847 there was a Jesuit priest who was living in this tiny village called Katayama in the prefecture of Hiroshima. So it's you can't find the village anymore. Trust me, I've looked on many maps, but it's in the prefecture of Hiroshima. And there was a freshwater lake there, and all the brides in Japan at that time, they are understood about the idea about not inbreeding, and so you would often have an arranged marriage with a bride from another village. And this is a bride being brought to the village to marry her husband. And what would happen is part of the pre-wedding rites would be that she would wash in the freshwater lake around the snails, and then she would get what he described as Katayama fever. And actually it was with Schistosomiasis japonicum, which was really quite a severe fever, and in 1847 many of them would die. So it was sort of the curse of the village, if you like. Okay, what's A shouting out? Does anyone know? Haven't seen any of it in the UK. That's intercalatum. B? So B and C are, B is Makongi and C is Japonicum. So I've tried to do the pictures so that B is a little bit smaller, because I think that B is meant to be a smaller version of C, and they are the ones that are associated with the most severe illness in the literature of acute schistosomiasis. D, thank you, and E. Okay, which one makes the serological test in the UK? I'm loving the fact Laura's not here, because Laura Navarro knows all the answers to this, as does Michael Marks, but they're not here. Okay, so the serological test is derived from Mansoni, which may be one of the reasons that we see a differing sensitivity when we test people in the UK. Great, good. So I've got something to teach everybody, but did anybody get all of the answers right? Because then they definitely deserve a pint, at least. No, great. I'm richer. So I thought I'd tell you about an acute case that I saw here when I was a registrar in 2011. He was someone who was repatriated to London, although he was actually from the US, with 4 weeks of fever. And he'd been living in Bamako, working as a security officer, and had gone to some waterfalls near to Bamako before he presented with these symptoms. And so when we saw him, he had fevers which had been going on daily, not particularly high, sort of up to 38.5. He'd had a bit of a cough about a week before he came to HTD, a bit of a rash, and this is actually a picture of his son's rash, who had the same rash. And that's the rash, and he also had a bit of a headache. And he wasn't really terribly unwell. As I say, he'd been living in Bamako. He had hiked up to this waterfall, and this is a picture of him and his children jumping into this lovely waterfall, and they all very reliably described this burning sensation on their skin after they had been swimming, which we all know is swimmer's itch. So when we saw him, he was pretty well. He had this stonking eosinophilia, and some raised inflammatory markers, raised liver enzymes, and not much else to note except for his schistosomiasis serology, positive at level 5, that's a strong positive. Level 1 is a bit dubious, but anything above level 1 we consider to be positive. And we're in the luxurious position at the HTD that we obviously got that answer fairly quickly. If you were in Romford or somewhere, then you might not get the schistosomiasis serology, but I think hopefully you might quite confidently have said this was likely to be acute schistosomiasis on the basis of the story and his symptoms. His didn't have any evidence of ova. As you may all remember or may not, Akatayama fever is thought to be caused by when the little schistosomuli, is that how I say it? Somula, something like that? That when they go and start to embed into their plexus of where they're going to end up as their resting point, that's the point when we think Akatayama fever starts, and actually it's often before they've started producing a lot of eggs. So we wouldn't expect a lot of ova to be seen in the acute phase. So we decided that he'd got acute schistosomiasis, and so we treated him with praziquantel. And again, there's a lot of debate in the wider ID world as to whether you really give praziquantel at this stage, because praziquantel isn't meant to be very effective on these immature worms. You're meant to really need an adult worm, which is why you should treat again in 2 months' time. And then some would say that in the absence of being a bride-to-be in Katayama, it's a fairly self-limiting illness and they'll probably just get better on their own. And so therefore there's a bit of question as to whether you even need to use steroids, but you know, when you've got them in your cupboard, you tend to throw it at them. As I mentioned, some of his family were also unwell, and they all were subsequently shown to have Katayama fever and were treated. I've called it on here acute schistosomiasis. Again, there's lots of debate. People like to call it Katayama fever. It's the word we know, but it's fairly good stuff out there in the literature now to say that you don't have to have a fever, so it might be a little bit misleading. So acute schistosomiasis might be a better term. Anyway, as a result of that and a couple of other cases I was lucky enough to see when I was here, I thought we'd look back at one of the databases, or in fact 3 of the databases that we hold at the HTD, thanks to the wonderful Maggie Armstrong, who's one of our research assistants or research leads, is that her term, research assistant? She's just Maggie, she's amazing. And she puts all the inpatient database, taking everything that has happened to people who've been on the wards under us, and an outpatient database of everybody that we see in clinic and in the walk-in clinic. And she also often ties that in with the lab results from the parasitology lab. So she was heavily involved in both this little retrospective review and also Cordelia's, which I'll mention later. And so we decided we had to have a case definition because, as I said, you don't have to have positive schistosomiasis at the very serology at the beginning. So that was our case definition. They had to have some symptoms. They had to not have anything else. they had to have had an appropriate exposure. They had to have had an eosinophilia at some point in their illness, but I was quite keen that we didn't have it at the beginning because, in fact, one of the other cases I saw had a normal eosinophil count of 0.39, I think, when they first came in the door, when they were symptomatic. Okay, so we looked over a 14-year period and found 80 cases. And if I want to take one thing away from this slide, you get an extra large Jägermeister bomb if you can work out which of the two ID doctors is more likely to get schistosomiasis and who they are. Any guesses? And in fact, both of these people, no, the bottom lady didn't have schistosomiasis, top chap did. Does anybody know him? I'm thinking the only person who might know him is James Seddon. I don't know if any of you know him. He's a great friend of mine. He's an infectious diseases paediatric consultant now. And he was surfing on our elective in Malawi, as you can see, body surfing. He wasn't very good at standing up. But needless to say, the person below is not me, actually. It's Eleanor Moore from Addenbrooke's. She's a consultant there now, and she's far more sensibly clad. And as is kind of a common theme today, if you're a young male traveller, you seem to be more likely to get these illnesses than if you're a woman. So there's another advantage to being female. Most of my cases that I saw in this review were from Malawi, but as you'll see, the pattern is changing a little bit. The classic triad of fever, cough and rash is not as common as we would like to think it is, only 13%. And I say 16% reported swimmer's itch, but a lot of the time it's just that it was never asked about. So if you take another thing away, it would be, if you think they might have it, ask if they've had freshwater exposure and ask if they had an itch when they came out of the water. So most from Malawi, but an increasing number from Lake Victoria, and now a bit more coming from the west part of Africa. So what happens with a Katayama fever is that they get exposed and then they carry on with their holiday, and unless they're on the shores of Lake Malawi and taking praziquantel there and then, which probably does very little, they won't really think about it again. And then a median of 42 days before they present with those are the main symptoms: cough, fever, rash and diarrhea. And then, because they're not that bad, it takes them a couple of weeks on average before they actually present to a doctor. So just sort of thinking about slightly longer time frame, certainly than Ebola, but than a lot of other imported infections. And this is just to make the point that the majority of them, 16 in this column, 16 in this column, and 11 here, had fairly unexciting eosinophil counts, could easily be missed. An eosinophil count of under 1. You might well miss that when you're looking down a list of blood results. And at the beginning, 65% had a greater than level 1 serology when it was tested. But that does also imply 35% didn't have positive serology when they were first tested. Okay. So we at the HTD ended up treating 95% of them. Because these are young male travellers, a lot of these people are at university and a lot of them DNA'd follow-up. So if they came back to follow-up, we gave them a second lot of treatment. But a lot of these people wouldn't have had their second dose. And we've changed the practice now so that we try to give them the praziquantel to take away with them when they go home, being pragmatic that they probably won't turn up when they feel well. As I say, some got steroids. That really depended on how sick they were. Many didn't, and nobody was particularly sick, so it's nice to tell you about a disease where no one died. So this is a second case, and perhaps here we might need to be a bit more worried about being female because she's a 22-year-old female medical student. She was doing her elective in Uganda and Kenya and dutifully went along to the HTD for a travel screen on her return 3 months later. She didn't have an N-terminal urine done at that time. I don't quite know why that was, but her serology was negative. So she went off back to university, got a new boyfriend and started having sex with him and developed lesions, genital lesions, which she thought were anal warts, and indeed so did the GU clinic. And so she got treated with podophyllin. And that actually made things worse, very, very painful, and things weren't getting any better. And that was when I first heard about her. You've all had your lunch. This isn't these aren't her genitals, but I just thought I would just point this out. So this is in fact a Belgian medical student, so maybe there is a risk factor there. And she's been reported in the literature here. And this is her lesion here, which you can see she's got swelling of the labia minora, and she's also got some lesions. They don't project terribly well, but they're down here. And they, again, like the other case, were mistaken for warts, and she had cryotherapy in this case. And then that's the histology when things didn't get better, which was much the same in the case that I saw, and that's schistosoma hematobium ova. I think that's meant to be the N-terminal spine there, yeah, surrounded by granuloma. So once the case was biopsied, she got praziquantel and it all melted away, and I'm pleased to say she's not had any problems since, and is doing very well. So Cordelia decided when she was at HTD as a registrar to look back at all the cases of schistosomiasis that they'd had over 15 years, so not just the acute cases. And again, you'll see a certain familiar theme. Maggie's very important to all this kind of work, so is Peter Chiodini and Chris Whitty. And in this case, there was a database that had been already set up for Cordelia, collecting schistosomiasis patients, and the case definition for them was they either had to have ova found somewhere and or positive serology. She got 1,000 cases over the 15-year period. The majority of them were in tourist travellers, and what this graph is just showing is the fact that actually the amount of schistosomiasis we're seeing at the HTD is decreasing. In 2012, it was under 50 cases. And it's not just that we're doing less work at the HTD. The green line is to say that this is as a proportion of the amount of work we're doing. So we're doing just as much work, we're just seeing less schistosomiasis. And really to say that although majority of Cordelia's cases were also from Malawi, there is an increasing tendency for them to come from really everywhere throughout Africa, although she hasn't really got much West Africa represented there, Ghana, and Nigeria, I suppose. The type of schistosomiasis we're seeing in the UK is hematobium. So coming back to the serology, we see hematobium. Our serology test is derived from Mansenai antigen. What else to say? So how do they present? So not very many of you have seen that many people with actual symptoms of schistosomiasis, and that's not really surprising. A third of those 1,000 cases were asymptomatic and just attended a post-travel screen. If they were going to have a complaint, they may well come through GU services. So that's when your brain needs to click into it, and a bit like the case that I saw. It was just something funny. GU doctors thinking that anal warts aren't anal warts. That makes you think something's funny's going on. Men tend to often complain of hematuria or hematospermia, so that was the second most common complaint. Overall, what she then did was take just of the 1,000 cases, the ones that had positive ova, and then look at how sensitive the serology was, the serological test was in the UK. So this is quite useful data, I think, for us guys, because when we're asking people to send off schistosomiasis tests, it's quite useful to be able to remember in our minds that overall the sensitivity of that test in this population is 86%. It's more sensitive if you're a traveller than if you're an expat or a migrant, and obviously, as I alluded to, it could be more sensitive if you've got Mansenai. So basically, if you're a traveller, you're more likely to have a positive result whether you've got hematobium or Mansenai. And if you're an expat or a migrant and you're thinking about hematobium, you've actually only got something more like about 76% sensitivity for the hematobium in the expat migrant group, if you see what I mean. Okay, so in summary, you don't have to have an eosinophilia at the start of your illness with acute schistosomiasis, so think of it even if it's not very high. If you're a young male traveller who's asymptomatic, that's your classic case, so you'll probably never pick them up unless you go to post-tropical travel clinic. Hematobium is the most common type of schistosomiasis, and your serology is less sensitive if you're a migrant or an expat. That's all I've got to say. Any questions?